This program is to demonstrate the correct application of the B-Lynch compression sutures and emphasizing the special features. Historically, it is well known that postpartum hemorrhage has been a problem for many centuries. Queens have died, princesses have died from all these unfortunate episodes of postpartum hemorrhage. Currently, we know that 375,000 women die every year around the world from PPH. 75% of these women die in developing countries. The reason for death is commonly delay in taking action, lack of protocol in the obstetric department, and also lack of training and expertise of those that manage patients in labor. The reason for this DVD is to demonstrate the correct application, which Dr. Javid, a very experienced senior registrar, will demonstrate now whilst I supervise the application. Dr. Javid.
First of all, I need to emphasize on that what are the, before applying the B-Lynch suture, what are the prerequisites. Either you're applying on an already incisional scar of the cesarean section, or you have to make an incision to apply the B-Lynch suture. The most important thing is you make sure this postpartum hemorrhage is not due to other trauma like cervical trauma, any extension of ankles, or any tear. So if there is any tear, you have to suture separately, because B-Lynch suture is only for hypotonic uterus in order to compress the uterus to prevent, to arrest the hemorrhage. The landmarks or the surface marking for B-Lynch sutures are, this is the uterus, so this is the incisional scar, so, and then this is the uterosacral ligament, which is important to know. So the suture, and then the other the landmark for applying B-Lynch suture is you need to know what type of suture we are using. We're using polyzob like one, and with the, which is 90, it should be 90 centimeter in length, and the needle should be blunt in order to prevent the injury to the surgeon, and it should be 70 millimeter in with a curved needle. Okay, so this is the low anterior leaf of the uterus, and that's the posterior leaf of the uterus, and you have you had make sure that this is only a PPH is due to atony of the uterus. So first of all, you apply on your right side. It should be about 3 centimeter below your incisional scar at level. Okay, and you go from outside to inside of the cavity, and then coming from inside to outside about 4 centimeter above the incisional scar. You make sure that you put a needle holder or the artery forceps to keep so that to keep that thread not to lose, not to lose that thread. Now you go back, come back, and this, at the level of the uterosacral ligament, come inside the uterine cavity like this, and make sure that you don't lose this thread. Then from inside of the uterine cavity, go back to the posterior surface of the uterus, come out and loop the thread. Okay, can you hold this, Prof? Loop the thread. Okay, and then from the top of the uterus, go back just up the same 4 centimeter above the uterine, above the incisional scar. Come out, then go from inside out 3 centimeter above the below the incisional scar. Okay, now with the assistance of your assistant, to compress the uterus as much as possible. And just you put a clip here, because you're not going to tie the suture until you have closed the uterine incisional scar. So for example, if I have just done that and closed the incisional scar, now I'm happy to, and you can check the back of the uterus that it is symmetrical, the same level. And now you can just, with the help of your assistance, you
don't tie it because
yeah, I'm not tying it. So
put a clip on it.
Yeah, so I'm just, with the help of the assistance, as much as you can, and you can tie here. So, and you can see compression, yeah, and then we can show you the other. If I can have that done, because, like for example, I have already locked in this one, and you can see how much squeezed uterus is in order to arrest the hemorrhage.
This can't relax.
And this can't relax. And then now Prof can explain the special features.
Yes. Now we shall discuss some of the indications for B-Lynch suture application. 1. Atonic or hypotonic uterus. 2. Multiple pregnancy uterus. 3. Polyhydramnios. 4. Pregnancy fibroid uterus. Because fibroids flatten and thin out in pregnancy, and therefore compression is effective. Placenta accreta, inquita, and perquita. Previous placenta previa. The preeclamptic uterus, which is usually full of blood and congested, especially if it's bleeding. Uterine malformation that has disproportionate size of the uterus, particularly if the pregnancy is in one home. Maternal obesity, because of the risk of bleeding postpartum and return to theatre in a morbid state. Microsomia, which distends the uterus quite significantly with the size of the baby. Prolonged labor and its venous congestion in the pelvis, and patients with previous postpartum hemorrhage are some indications for the B-Lynch suture application. The special features of the B-Lynch compression suture is you establish even tension, so there is no bias of compression and therefore slippage of the suture at the fundus. Also, for this reason, you avoid venous congestion obstruction, which causes ischemia of the central portion of the uterus, as described by previous publications. The procedure allows free drainage of the cavity and avoid pyometria or hematocorpus. There is no shouldering. It facilitates involution because if uterine fibers are compressed and they shorten, and they can facilitate early involution. It's easy to confirm hemostasis both by the assistant in the vagina checking that the bleeding is controlled, and the drainage allows blood not to collect in the uterine cavity. It can also confirm empty cavity, confirms there are no retained products. It's easy to confirm that no decidual tear or trauma. Final note, the French workers have done studies to show the comparative risk of Asherman syndrome in all compression sutures published and described. The only suture technique that does not create Asherman syndrome is the B-Lynch procedure, because there is no apposition of the anterior to the posterior part of the uterus like you get in the Chow procedure or the Heyman's technique, where the cavity is not open and the tension is not distributed. The cavity must be allowed to drain passively. If this does not occur, there will be collection of blood in the cavity, infection from debris, and therefore adhesions formed within the uterine cavity. So it is my strong view that the cavity must be open and drainage should be facilitated in all attempts to apply compression suture.
Prof, I wanted to confirm what material suture is recommended for this B-Lynch suture.
It's an interesting question because the first time the B-Lynch suture was applied was in 1989, and then it was catgut that was used on a big needle hand application. But since then, and more recently, catgut has been banned because of CJD, mad cow disease, and now the recommended suture is monocreel number 1. Because monocreel number 1 has got a half-life of 21 days and it will dissolve without trauma to the uterus. Vical is not recommended because it can cut the uterus and it takes 3 months to dissolve. The needle size for the application is semicircle, 70 millimeters in length or semicircle circumference, and the length of the suture should be 90 centimeters. Those are the two important information about the suture material and why that is particularly selected.
Can I ask one more question? So the needle can be blunt or it should be
The
sharp?
needle must be blunt. When this suture technique was first applied, it was a sharp needle. The surgeon, myself, had to wear a thimble to prevent pinprick injury. But now, because this new suture, specific for this purpose, is blunt, you do not need to worry about pinprick injury.
Thank you. Prof, is there any historical background of postpartum hemorrhage which we could have prevented by applying this B-Lynch suture?
Yes, many years ago, many centuries ago perhaps, queens have died from postpartum hemorrhage, where something like the compression suture may have saved their lives. For example, the Mumtaz Mahal of India, who was the wife of the Shah Jahan, the emperor, died of postpartum hemorrhage after delivering the 14th child, whilst the emperor was out on a professional mission. Her uterus was hypertonic because of the grand multiplicity, and compression suture could have saved her life. In memory of this event, the Shah Jahan erected the Taj Mahal, which still stands in memory of this event. Also, the Princess Charlotte of Wales, who had a previous bad obstetric and pregnancy history, had a fortunate pregnancy which was intrauterine, but became postdated, 10 days overdue, and went to spontaneous labor. The baby was big, the head was high, and the obstetrician, Sir Richard Croft, performed a high forceps delivery, which was traumatic, and the Princess Charlotte of Wales died of postpartum hemorrhage. Again, this is a situation where probably a compression suture would have saved her life. The obstetrician was disappointed and was criticized by his colleagues for the way he managed the pregnancy, and he shot himself. So this one episode of pregnancy had 3 lives: that of the Princess Charlotte of Wales, the son and heir, and the obstetrician who managed the pregnancy. There are many more evidence published of postpartum hemorrhage affecting royalties as well as, normal women worldwide, which now has fortunately been saved with a record total of over 8,000 successful application of the compression suture. So we're all very pleased that we're making progress somehow.
Prof, is there any space of B-Lynch suture in modern obstetric procedure?
Yes, there are situations where in placenta previa, once you applied the suture to compress the lower segment, remember the obstetric principle is the upper segment contracts and the lower segment retracts.
Yeah.
So therefore, bleeding from placenta previa can be quite heavy and frightening. So by applying the balloon introduced from the abdomen and the B-Lynch suture, you can have like a sandwich technique or sandwich effect, which can control bleeding from the lower segment as well. In the brachy balloon, after a normal vaginal delivery, the first principle is to apply the balloon vaginally, and if it does not work and you have to open the abdomen, then it's worth using a sandwich technique to compress the uterine cavity as well as applying the brace suture to compress the uterine musculature and the lower segment.
Can I ask you, like, even if, while we're doing cesarean section and there is placenta previa, and there is a bleeding from placental bed, so if you apply the brachy balloon and then you can still put the B-Lynch suture?
Yes, that's right. This is effectively you're compressing the cavity as well as compressing the muscular structure. The sandwich technique works very effectively, but it's to know when to do it.
Yeah.
My suggestion would be you apply the B-Lynch suture first. If you check the uterine cavity, there are no reason to put independent suture like in the decidual tear. We've had in my hospital an example of where a normal delivery had occurred by a midwife. In the 3rd stage, after delivering the placenta, the patient poured blood quite significantly. We put the balloon in, it did not control it. When we opened her up, we found, on opening the cavity, that it was arterial bleeding from a decidual tear when the third stage took place. We transfixed the area of arterial bleeding first, and then put the brace suture, and the patient survived.
So I understand, like, if we apply the B, as you explained, that if we apply B-Lynch suture first and we put the balloon, at least then the balloon will expand according to the size of the cavity with the compression of the B-Lynch suture.
Yes, that's right. And this is why you have your assistant between the legs of the patient. When you do that, they can monitor the control of the bleeding, which is essential.
Thank you.